We talked about the before. Let's talk about the after. Dan, what is your routine aftercare for LASIK?
Yeah, I have a hair trigger. So typically we do a combination drop that we use 4 times a day for a week and then 2 times a day for 3 weeks afterwards. And that
And
combination
just to
drop,
clarify, combo drop is a steroid, the one we use for LASIK, typically steroid antibiotic.
correct, steroid antibiotic, and usually it's a fluoroquinolone is the most commonly used. They're really well tolerated, great on the ocular surface. Not a ton of interaction with MMP, not the MMPs. There is some interaction, but very little. So it's great for the ocular surface typically. Oftentimes they can be non-preserved also, but we use it in one drop, so it's really easy for the patient. And we typically don't do any NSAIDs or anything like that for our LASIK patients. Now for PRK, sometimes we'll use it for patients who have pain. But for LASIK, we're typically doing that. And then I have a hair trigger for adding an immunomodulator like cyclosporin, especially any sort of symptoms that they have. I'll do it for a month before LASIK and a month after, sometimes 3 months after. And it's just to get them through that temporary dry, or it's really not even dry eye. It's that ocular surface healing that has to happen after a surgery. And there's been a lot of studies that have shown that helps. And then, like Doug mentioned, temporary punctal plugs. Usually I do that at 1 week if they have any sort of staining, but sometimes I'll do it before. But typically at 1 week, if they have any sort of staining, I'll just pop those collagen plugs in there to get them through that first 60 days or so of toughness. So that's typically what I do. And like you said, with the see and do process, it's really easy for people to come and do that one really important vision trip of their lifetime, where this is their one chance to do this. They want it done right, and then we can do that aftercare with their doc close to home.
Love it. Doug, what's your typical follow-up rhythm? Most of these patients are seeing their primary eye doctor afterwards, but what do you recommend for following these? What's your frequency or interval?
Our interval is at 1 day post-surgery. Then we go out to 1 month, and then I'll do a 3 month. And then at the 3 month, I'll just have the discussion with the patient, depending on how they're doing. I'll say, I want to see you one more time, whether that would be a 6 month check or whether you want to just move it all the way to a year. And that's kind of what I tell the docs that we work with out there. You can be the judge if you want to push that 3 month out to your just annual eye exam if you want to. And so sometimes I'll just push them out to that and say, we're here, we're just a phone call away if you need us. They're 3 months out, they're 2015 uncorrected, they're happy with everything and really comfortable. Then I tell them there's probably not going to be a lot of change. Although from 3 to 6 months, a lot of people with LASIK still feel like they got an improvement in their sharpness and clarity, certainly true for PRK patients. And so they may get a little bit sharper and clearer. And maybe they might say, well, can I just come back at 6 months just to check and make sure everything's fine? I'm completely fine with that. And then move it out to the full year. We used to do a week check, and we kind of let that go. The week checks were really not doing a whole lot for the patients. We give them really, really good instructions. And when they're with their co-managing doc out there, they've got really good instructions. They've got the access, so they know if there's anything that they're concerned about, what to look for, then give us a call or their co-managing doc, and they can see them at a week if they need to. But generally, that gives them a chance to get off those medicated drops and kind of settle in and recover by the next time we're seeing them. And then we can really help them with, okay, here's what's going to happen over the next several months.
Yeah, it's interesting, Doug. We did a big study here looking at topo-guided LASIK, and when you look at the FDA data from 3 months to a year, there was statistically significant improvement in those patients' vision with topo-guided LASIK. Is that cornea regularizes and the epithelium then regularizes back to what it should be after you've taken care of any irregularity. So it is really surprisingly not that uncommon for people to get better from 3 months on, even if they're not really happy. And that's why, being a little bit of patient on an enhancement and not rushing into it. Is sometimes a good idea, especially if they've got minimal refraction and are just really saying, it's just not as quite as sharp as I would like. So,
and I guess the last thing I'll throw in there on these follow-ups, because most of them are being done out in the community. The ones that aren't being done out in the community are our research patients, because if we have a research trial going on, which we frequently do a lot of, Vance himself was involved with the initial laser trials for PRK and LASIK. Doug, you too. And so, you know, typically when a laser gets FDA approved in this country, we're one of the sites that's running the trial. Same with ICL or implantable lenses as well. Those follow-ups are being done in-house because how the FDA works is they have to have a site monitor and they have to actually come and sign off on all of the equipment. They have to actually come in for routine checks while we're actively enrolling and following up for these studies. And so it's a very tightly regulated process. And so for that reason, study patients are coming back and we have to follow them in-house. But
some of the protocols have relaxed a little bit. That's one of some of the earlier clinical trials. It was all had to be done at the research center that did the procedure, but some of the clinical trials allow for the co-managing doc to do some of those visits, and then the research has to follow them at certain intervals. So sometimes the co-managing doc gets to get involved in those research protocols too, and kind of seeing where their patient was randomized to and stuff like that, which is kind of fun. So for them to see.
All right, last thing I think we'll touch on, and maybe only a couple minutes here, but you know, I think probably the biggest two things are for LASIK follow-up. What things are you looking for? Now, if you're, you know, to the community docs listening that are doing these follow-ups for LASIK, what are you really looking for on that post-op day one visit?
I'm concentrating on how their flap looks at day one, and so we're in our in-house here, we have some surgeons who do flap checks right afterwards, some who don't. But that 1 day visit is to make sure that the flap is where it should be, that there's no excessive inflammation. There's no, you know, the femtosecond laser, when it makes the flap, also makes a little vent superior to let some of the gas bubbles that the laser creates out. And sometimes people who've worn contacts for many years, of course, they have a little bit of superior neo. That laser hits that, and there's a little bit of heme built up there, and sometimes that'll trickle down into the flap or is spread out along there. And if it's pretty significant, we might want to see that patient back to rinse that out, just because they might have an immune reaction that might trigger some inflammation. And so I'm checking the flap itself. With laser made flaps, you can check the gutter of the flap very easily and make sure that it's even all the way around, even at 1 day. And you can look at the interface of the flap and you can see if it's clear, it's smooth, you can see any microstria or irregularities that are there. And then make sure that what you're seeing in the slit lamp matches with what your patient is saying and what they're measuring on the chart, okay? And then if all of that is looking good, then you're okay to let them go for probably 3 weeks until you see them again, and make sure they're following their instructions. So that's really what I'm concentrating on day one.
I love that. Yeah, you know, the things I'm rinsing out on day one, because I would say like the big thing is to decide if you're going to do something differently. And so I think there's two things I will potentially do differently. If I see some white blood cell, so the patient's a little photophobic, there's some white blood cell recruitment, maybe it's from an early DLK, whatever's causing that, little staph marginal or a little epithelial defect or whatever it is, we can bump the steroids up. And most of the time, a stage 1, stage 2 DLK, you bump up prednisolone and it'll just go away, you know? But if it gets a little bit, you know, if it gets to that stage 3, maybe stage 4, and things aren't turning a corner, we're rinsing on day 1, 2, or 3, but I'm following those patients closely. So I'm making the decision on, do they need a post-op day 2 now? Are we increasing drops or not? And then, you know, the flap lift rinse. If there's, you know, if a fiber snuck under the flap, you know, red blood cells, I'm often not rinsing out, assuming it's not causing a DLK. Also, if it's not in the visual, you know, if they're 20/50 from a little bit of heme that snuck into the vision, it's pretty easy for me just to rinse that flap out and get them better vision right away. It probably fades. It will fade with time. But I'm often rinsing those just so those patients are happier quicker. I'm not rinsing any meibum. Meibum gets under the flap, not uncommonly. That's not visually significant. It usually doesn't cause any inflammation. And so, so that's one thing I'm doing. The other thing I think on the follow-up is we're deciding for a fine tune. Dan, what's your decision, you know, post-op day 1, post-op week 1. When are you pulling the trigger on potentially doing a fine tune?
Yeah, kind of like we talked about earlier, it's not until 3 months.
Yeah.
I want their cornea to, and preferably later, but like 3 months at the earliest, because I really want to have that cornea regularized. Their dryness should mostly be gone by then. And so I am waiting for things to regularize. I want to repeat epi mapping. Hey, did they just have a bunch of hyperplasia of the epi, and is that going to settle back down? What's happening with that? And so I think you can easily lift a flap within the first year for a fine tune. Going out past a year, it gets still very doable. But, if I'm going to fine tune someone, it's usually in the 9 to 12 months after surgery is kind of that time period. I think is kind of a nice sweet spot where their refraction stable. It hasn't been too long that the lift flap should go pretty smoothly.
Yeah, and I generally talking about it at the 3-month visit.
Yep.
We call our patients at that 90 to 100 days. How are they seeing and all of that? We get them in for an eval if they feel like they aren't seeing as good as they'd like to. And I'm usually measuring. And if it's a plus a quarter minus a half refraction, we're kind of, talking about, hey, we don't want to chase our tail with the laser. Let's see if we can optimize the surface a little bit. If they're sitting at, if they have a little bit of surprise astigmatism or anything like that, then I'm really saying, okay, let's schedule a see and do. Let's cycloplegia today. Let's schedule a see and do in a month from now. And if the refraction's stable, we'll pull the trigger. If it's changed a little bit, maybe we pause again. And so that's kind of my routine. But yeah, I agree. The further you wait, the better. And we just don't want patients to get, too frustrated also on the same end. So, I've had that -2.5 engineer that came in, and he came in, at 4 or 5 months, and he was -1/4. And, he's like, golly, did I do it? Absolutely, I did it. I did it. And he called us a week later and he said, this is why I came to you. This is why I drove 3 hours down to you guys, because I knew you'd take the best care of me. And you heard me, I was 20/20 unhappy. My other eye was better than 20/15, and I was 20/20 unhappy with this other eye, and I noticed it because I'm an engineer. And we fine-tuned him and he loved it. So, and that's where it's just listening to the patient. Every patient's a little bit different.
I agree. I like saying it that I start the conversation about a fine tune at 3 months and reassure the patient that even if they're unhappy or didn't not where their expectations were, that we're starting the conversation now because I'm letting you know that you're correctable, which means you're fine tunable. Now we just have to make sure that it's stable and then get them to go that next 3 months or 6 months or whatever to make sure you've got the stable measurements and make sure that there's a chance that they might not improve on their own. And so I started at 3 months. Earliest we probably fine tune is 6 months. And depending on now we bring in epi mapping and some of those other things, we may be waiting a little bit longer as that cornea might normalize a little bit, especially in those small residual refractive errors. And it's pretty rare that you have a big residual refractive error after a LASIK now. I mean, we don't miss it by a ton very much. So you're usually dealing with pretty small refractive error, which makes a tougher decision most of the time.
All right, guys, all good thoughts. I think we're going to wrap this sucker up. Any other closing thoughts on LASIK? I mean, we're still doing a lot of LASIK these days. I mean, it's a great option. Again, we said not the best option for everybody. It starts with, a little motivation to get out of glasses, contacts. But any other closing thoughts on LASIK?
I think LASIK's in probably the best space it's ever been in the last 30 years. And the reason is because all of the other technologies have allowed us to not have to push LASIK. And I've been through all of the technologies from the early MKM and RK days all the way up through. And now the nice thing is LASIK doesn't ever have to be pushed to its limits. You can settle in with LASIK and PRK in these wonderful patients that are moderate myopes and hyperopes and astigmats, and you just get these wonderful results. And then anybody that falls outside that range, look at all this cool technology we got that can correct them and not have to push them. And so I think it's in a beautiful place right now. So.
Love it.
Well said, Doug. Thanks, guys.